The Wall Street Journal did a recent piece called Generation Xanax, the dark side of America's wonder drug. A friend of mine called me, said check it out, because I had just done a couple of videos on this issue. The article was published on March 13, 2025, just a few days after I had covered my topics regarding the important issue of chronic benzodiazepine withdrawals. What I did was separate the short-term withdrawals from the long-term withdrawals. I also did another video on the same topic, benzodiazepine withdrawals, but I talked about anti-seizure medications and their role. They can be found in the description below. But shortly after I did my videos, this article came out. Why this is important, why this article is important, and the fact is that for the subset of patients that are suffering from this condition, and the condition I'm talking about is long-term benzodiazepine withdrawals, it can be absolutely devastating. This article did something very important. It really helps validate and bring to light and legitimize a debilitating and under-recognized and underappreciated condition by the general medical community. This is one thing that I'm not sure if the article really pointed out, but the thing that is of consideration here is chronic benzodiazepine withdrawals. It is real. And there's a large enough number of patients suffering from this issue that more spotlight needs to be shed on it. Let's also keep something in mind to keep it real, okay? This is only a subset of the overall number of people on benzodiazepines worldwide. I think the number is 24 million. And maybe later I'll come back and point out why this is important, that this is relatively a small subset of the patients that are on benzodiazepine, but a large enough number and a very debilitating condition. Let's look closer at the article, and I will shed some thoughts and add some thoughts and considerations. The article is well written, and again, it sheds light on stories that are too often dismissed. But like a lot of journalistic pieces, it does need some clarification, especially for the medical community and also the patients who are suffering from this today. Because as I said, it is something that is not really established in the medical clinical community. And this causes a lot of despair and further suffering for the patients. I treat many of these patients, and many of them successfully. And often the very first step is grounding them in clinical reality, where it is often, their reality is often taken from websites, communities, patients that share the same issue, and there is this algorithm and outlook towards the issue that is really not grounded in a clinical approach to things, and that can be harmful. So my first step is always grounding them in reality, informal thinking, and approach to this situation. And I think this is warranted in this case, as well as to make sure any unintended hype from the article is dispelled. I also feel many clinicians out there are having a hard time dealing with this issue when they encounter it, and I hope we can bring more comfort to the situation for the clinician. Okay, standard withdrawal versus protracted benzodiazepine withdrawal. This article, although it discusses it, does not clearly or do enough to distinguish between the standard withdrawal, which the medical community recognizes, and the protracted withdrawal syndrome, which is something that really remains debated, under-researched, complex, and denied by many clinicians. And I think this needs to be pointed out, and this is one of the most important things this article did, was validate this reality. I really want to highlight that difference for all the stakeholders in this issue. Let's lay it out again. Standard withdrawal that the medical community recognizes, and the protracted benzodiazepine withdrawal that needs to be pointed out as a separate thing from the standard withdrawals, and the medical community has, for the most part, never recognized, and it's not really something that is in the clinical literature and any guidance or guidelines traditionally until some recently. And still, to this day, many in the medical community deny it, which makes care for the patient even more complex and suffering reaches greater heights. The lines slightly blur in this piece, but they do a pretty good job. I don't want to criticize them. I just think it's critical to really flesh this out. The major issue is the chronic benzodiazepine withdrawal. And the medical community has historically refused to recognize this, and this is really what this article is about. They didn't blur for me when I read this article, but that's because I know what they're talking about, but it may for some people. This is where most, in fact, the clinical confusion and patient suffering occurs. And I recently created, as I said, some videos to facilitate the distinction between acute withdrawals and long-term withdrawals, and I do a little bit of a deep dive on it. Okay, enough on that. Let's move on. The other issue I want to point out is the subset of patients suffering from protracted symptoms. Those suffering from long-term debilitating withdrawal symptoms from benzodiazepines represent a subset and not the majority. The article did in fact point this out, but I think it's really important to draw this out and again flesh it out and sort of just put it out there and remind everybody what we're talking about. It's actually a small subset of the 24 million people relatively, but it's also large enough to be of concern and debilitating enough to be of concern. I'll leave out any hard claim to the percentage of patients due to the controversies, but I will say with some reservation that 10% is a good reference number to kind of keep in your mind and think about, which is a large number of 24 million people. I do not say this, and I do not point out that, hey, this is just a small subset of patients of the 24 million of people, because I just in general am advocating for benzodiazepine use. Not at all. In fact, back in the day when these things were being handed out like candy, I was kind of stunned. But the distinction matters in today's climate of outrage, overcorrection, and approaching all social issues with anything and everything emotional but formal thinking, including our public policies in general for decades. The last thing we need is to have a reactive push to rip everyone off of these medications, especially people who were started on these medications years ago. Often inappropriately, but those whose nervous systems have adapted. This is important enough of an issue that it needs pointing out in today's general environment and public policy, medical approach to things. Sure, we need to look at those patients and make fine adjustments, maybe. Clinicians must absolutely understand this. We could spend hours unpacking this issue, this topic alone, and the harm done by thoughtless clinical approach to these patients and causing a lot of suffering. We need to leave them alone. Next, all of these issues are actually related. Keeping that in mind. The clinical complexity of the situation and the topic of causation. That's the next thing I want to point out. By causation, I mean clinically, scientifically, statistically. That is what I mean by causation. This is a scientifically and clinically convoluted issue. We still don't fully understand why some patients are vulnerable to these long-term symptoms and others may not be. Someone on benzodiazepines for 10 plus years is in a completely different category than someone newly prescribed. Adaptations have occurred, whatever that is, whatever they are. These adaptations have caused problems, and maybe they haven't, but it has already occurred for those that are having problems. My point is this: clinical decisions need to be individualized, and you cannot have a shotgun approach to someone that is newly on benzodiazepines, or you're considering putting him on benzodiazepines, or someone that you are dealing with that has been on these medications for 10 or 15 years. You cannot take recommendations or just have blanket causation discussions that, hey, benzodiazepines cause central nervous system injury, for example, and you got to get off of this. This is really critical. Clinical decisions must be individualized. Blanket demonization is not helpful. And furthermore, it's medically irresponsible. This needs to be kept in mind by all clinicians dealing with patients on benzodiazepines. So to just say benzos cause this in an atmosphere that is reactionary and always looks for simple scapegoats can cause harm. Clinicians need to be not only critical in their thinking, but exercise some serious compassion in their approach. Moving on, I think this is number 4. Don't get confused, because all of these topics are related, and it's sort of a dynamic, it's a mosaic, and that's what a really skilled clinician should do when they approach these patients. Okay, let's go. This has to do with best practices of prescribing benzodiazepine. Dr. Ritvor's guidance in the article is strong and it's fine, but we need to keep something in mind. Best practice guidelines are at best guidelines, and a professional, a clinician, needs to use them as such and make their own decisions. But we also need to understand guidelines for benzodiazepines in a time of crisis has to be separated for new patients, for chronic patients, for those trying to withdraw, and for those trying to withdraw and are having problems with chronic benzodiazepine withdrawal. In other words, guidelines for benzos need to be separated and applied to each person, each patient, applying them to their condition and which category they fall in. Very different sets of patients. This is often overlooked in these situations and in the cloud of our reactionary approaches and sometimes undertrained clinicians to be able to discern between clinical guidelines, best practices, and recommendations. Now, for new patients, these guidelines really aren't different than what they were many, many, many years ago. And I used to be shocked why they weren't followed. Short-term use is what benzos are for. Close monitoring, careful consideration of alternatives should always be the first step. These medications should not be handed out like candy. And I thought this was really always the case and the way we should have approached it, but I suppose not. Let's move on to the next point, which is also related to my other points. For some patients, especially those with severe psychiatric illnesses like schizophrenia or bipolar disorder, benzodiazepines may be a vital part of a cocktail that has been worked out over many trial and errors over the years that has created long-term stabilizations for these patients. And these cases require nuance. What are you going to do? Rip off, let's say, a guy who finally found stability with his overall psychiatric cocktail, and he's on 10 milligrams of Valium 4 times a day, but has finally found peace, serenity, and ability to live life. You're going to rip them off of that cocktail and throw them into complete disarray? Leave them alone if they have found that stability, functionality. Now, add this to what I have said above, keeping in mind best practices for new patients, which do not apply to patients on long-term use, which do not necessarily apply with patients that are suffering from chronic withdrawal exposures, those in chronic withdrawals. Their paths, each path, must be laid out differently. See how complex and dynamic things quickly get? Again, stigmatization needs to be ignored because there is a nuanced, careful, thoughtful approach that should be utilized by clinicians. And there is a lot of stigmatization in this area, as there is such a thing called benzodiazepine abuse or addiction. So we as clinicians need to be careful how we approach these patients and how the public discussion moves forward. Let's move on. This article also mentions BIND, B-I-N-D, benzodiazepine-induced neurological dysfunction. The term BIND offers value for validation, research, maybe clinical discussions, sharing thought, but this has to be also used carefully. Again, in an environment where we take things too far, including stigma and the close relative of stigma in this situation, as I described, is benzodiazepine addiction, and people may be very quick to go there. Labeling this phenomena, and some, even call it brain damage, is premature and clearly has the potential to do harm. It stigmatizes patients, it scares off both clinicians and individuals who might benefit from thoughtful care, a different approach than ripping them off benzos. And those that are suffering can self-stigmatize. It causes more anxiety, more lighting up the stress response system. It reinforces a destructive mindset in patients who fixate on irreversible damage rather than symptom relief and recovery. The goal should be healing, not labeling, not labels that provoke fear and foster obsessive behaviors. Let's move on. Again, things that are related. The article mentions micro-tapering, casually mentions it. I call it the micro-tapering trap. What often begins as a cautious tapering can spiral into obsessive micro-tapering, where patients are trapped in a cycle of fear and hypervigilance. This over-focus on withdrawal re-traumatizes the nervous system, often making things worse. It is trauma. This is trauma. Trauma that induces PTSD and makes matters worse. Let me repeat. This issue of constantly micro-tapering and trying to taper again and again causes trauma. This trauma induces a PTSD. PTSD can make matters worse and lights up the immune system and much more, the stress response system, which is intimately related. Let's stop all of this as well. When patients stay locked in a prolonged fight or flight state, symptoms can worsen. Not necessarily due to the drug, but from the cumulative stress of fear, isolation, and repeated failed tapering attempts, maybe from the stigma they're trying to avoid. Maybe they want to avoid the thought of being an addict to benzodiazepines. Stigma, 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 stigma. This can spiral into a psychosomatic illness, furthering their suffering, and much worse. There's always this culprit, and it's the benzo. Now you have a vicious cycle fighting this imaginary culprit, and I'm not sitting here telling you it's not the benzo. That's not what I'm telling you at all. And if you're focusing on that, and if you think that's what I'm telling you, you've missed the point. Look, a physician's role is to relieve suffering, not to moralize molecules. Every decision must be grounded in a dynamic case-by-case risk-benefit analysis, considering both short-term and long-term outcomes. This is really the case when we don't have that much data to rest on and to make our decisions. Benzodiazepines, they're neither demons nor saviors. They are tools. They are molecules. They are inanimate objects, and like any tool, they can heal or they can harm, depending on how, by whom, and when they're used. Let's not assign moral value to a pill. Let's lead with compassion, precision, critical thought, humility, and let's continue to learn and heal. Please leave your comments below. Give me a like, even if you don't like it, and subscribe. Doesn't matter if you agree with what I'm saying or not. I just want to induce critical thinking, thought, and maybe a reevaluation of some of your beliefs and approaches to such matters. Thank you.